seconds. Countdown 55 seconds. Well, welcome to the post-lunch, post-coffee bit of this conference. One thing you learn with design for fast food restaurants is to make sure the seats aren't comfortable. So when you have seats without cushions in fast food restaurants, they ensure that you don't get too comfortable. You pretty much depend on your own derriere, and the better padded you are, like some of us, the more comfortable you'll be. And otherwise, you get restless, your bum hurts, you need to walk around and so on, and it keeps the fast food meal fast food. Now, we're getting closer to the end of the day, and what we're going to do is have a session that's going to actually draw on your expertise. And this session is going to be about de-escalation, but not because anyone here is an expert at de-escalating, because there are just so many situations that can trigger. And what we'll try and do is build it into 3 parts, give a very quick overview about situations that may cause escalation or us to find ourselves facing aggression, threat, or violence. We'll have a simulation session, and then we'll engage in conversation as well. Just from a psychological, emotional safety point of view, the session may trigger some of us for all sorts of reasons. We may have found ourselves in situations of violence. Some of us may be living with trauma. Some of us may re-experience, but the objective, and we'll try our best, is to recognize the importance of this, whilst also hoping and trying our best not to. But if you do feel triggered by this session, please contact any of the organizers, Simon and myself, or the people on the table over there. They're going to wave a hand, and they'll be able to give individual support. They're very good, and they're very good at psychological therapy, because over our snack meal last night, one of them actually gave me very good cognitive behavior techniques for dealing with my long COVID symptoms, and a nod to my therapist, Jen, in the real world. So anyone can need help in these spaces. So we're going to be talking about de-escalation. Now, why does it matter, and why should we be talking about de-escalation and the management of aggression in a conference like this? Well, for several reasons. It can be quite common. If you drive down the street or you walk in some areas, you may see people in distress or dealing with distress or responding to distress that may come across in ways that look aggressive, or may leave people threatened, or may cause people to call the police or first responders. So agitation, aggression, confrontation, retaliation are things that occur quite commonly in this sort of work that we do. And all too often what we see is the manifestation, but oftentimes we don't know what lies underneath. So it's like an iceberg. We see the person behaving in a way that's disturbed or maybe aggressive, but what lies underneath? And it's so important that in whatever intervention we consider putting in place, that we're also very thoughtful about what may be causing this sort of behavior. Some of my interest in this space comes from another period in my clinical life, working for over 10 years, running a psychiatric intensive care unit. And what we dealt with was violence every single day. In other worlds, I've also worked with police doing training on management of violence and alternative ways of managing violence and mental illness, or when there are call-outs and so on that don't, by default involve chewing the pavement, losing your teeth and having handcuffs behind your back. or struggling to breathe as well. And interestingly, in some of the work with police, some of the police that I've worked with that have had the greatest empathy in this space, when we've had a private debrief or I've written a letter of commendation to their chief, are people who actually have siblings, family members, spouse, parents with a mental disorder and some or addictions. And somehow when we have a quiet chat, they say that could be my brother or my brother went through that. So that's what I was thinking of in managing it differently. So without boring with clinical things, we could go on and on about this, but some examples of situations that can underlie the bit that we don't see with escalated behavior or aggression. It could be various ranges of diagnoses or symptoms. For instance, psychosis. The person may be paranoid, psychotic, responding to abnormal experiences, a voice or seeing things, and feeling really unsafe in that situation. It may occur with paranoia. And a large number of people, when paranoid, are actually more scared. And when we're scared, we can behave quite differently. And if we struggle to conceptualize that, you approach a dog that's scared when it's backed into a corner, or a cat. You learn pretty quickly. It could be in the context of a person's personality. And everyone has a personality. One of my worst terms in clinical practice is the term personality disorder. I think it's one of the yuckiest, personally, disclaimer, this is just my view. I don't like, it's a label that sticks on and a person turns out emergency department, or that person's borderline, that person's a PD. And that's all anyone else sees. And there's the concept of diagnostic overshadowing, because once that label sticks, you know, like the saying to a hammer, everything looks like a nail. No matter what you say, all they're seeing, or, you know, the person's being coded and labeled with violence, even when they don't mean threat in any way. Or people presenting in an intoxicated state. And regardless of what they're intoxicated, whether it's alcohol, crystal meth, cannabis, you know, shrooms, but also in an intoxicated state where the sort of mental process they're dealing with in that state, or people with a learning impairment. And it's not, they're working within the capacity of their developmental delay or what they're going through, and they may also act in ways that may appear threatening or aggressive. The person could be struggling with an autism spectrum disorder, have ADHD. Now, you are someone with ADHD, hyperactive type, sits all day on one of these seats, or sitting emerge and being told, look, just stay on that seat till they call you. And the person's trying, but they can't. I mean, they just can't. And then they get up, please sit down. Now, this is the 15th time I'm telling you to sit down. If you don't sit down, I'm going to ask you to leave or we're going to call security. And these are difficult situations without context. People living with trauma. Trauma is such a personal experience that who has a right to inauthenticate another person's trauma? And what's going on in the person's head they're living with that we don't know? Pain. I conceptualize pain as real, and I conceptualize all pain is real, whether it's emotional or physical. If a person says they hurt. Whether we get it or not, they hurt. PTSD, post-traumatic stress disorder. I was on Via Rail train yesterday, and I had the most amazing conversation with the guy serving me on the train, just a chance conversation. And they're talking about the need to have trauma-informed care. They deal with so much trauma on the train and train-related incidents. So many of them are living with PTSD or have to de-escalate situations on trains in enclosed spaces and need more training. Perceptual difficulties, whether it's visual impairment, auditory impairment. The best whack I've ever had in my career was from a woman in her 80s. She was visually impaired with 2 walking sticks. And I was a naive, very stupid doctor at the time. And I thought, okay, if I got really close to her, then I can talk to her and say who I was. Rookie error as a doctor. What she saw was a dark form getting close to her without talking, and she felt under threat. And she poised herself with one walking stick, whacked me with the first stick. But I was so stunned in that moment. It was, did she just hit me? But for her, it was that hit didn't work. So she balanced on the other stick and whacked me, I mean, quite painfully. I could have ended up in emerge. And then I ran. And why so is she perceived threat. All she saw was what appeared to be a man walking up to her, not saying anything rather quickly. She couldn't see clearly, but just realized, okay, I've got to look after myself. I thought I was being really professional, but I was being a stupid rookie doctor who thought should have known better to at least project my voice and be a bit reassuring before getting into her personal space. I had no right in her personal space without permission. Or people leaving, going through sensory deprivation, and it could be darkness, poor lighting in a situation and so on. People living with head injuries, seizures, delirium in seniors, or people going through delirium for all sorts of reasons. And sometimes it's just boredom. Just so bored. And if you remember the good old days in high school, people are bored and they just flick something or just write a note and pass the guy next to you, and maybe just says potato head. and, and things like this can happen, but underpinning a lot of escalated behavior and aggression is fear, sometimes anger, sometimes confusion. How do we respond to verbal and nonverbal communication? And now let's begin to place and meet the people where they're at. Does the person have a weapon on them? And a weapon doesn't need to be a knife or a gun. It could be a crowbar. It could be a speaker. One of the neatest weapons, I hope I'm not teaching weaponry here, but one of the neatest weapons I've seen someone stabbed with was an orange peel. Oranges were cut into 4, they were dried, and you got sharp points on each end and lacerating edges. And this person lacerated and stabbed. And it was a very awkward court case. Is an orange a weapon or not? Enclosed space. Does the person feel entrapped in the space they're in? And are they managing their safety in that space? It could be that they're living with trauma or other experiences. Isolation. Perceived threats of harm or real harm. And people who attend to these situations would be people like you and I, first responders, members of the public. First responders including police, clinical ones, ambulance, fire, peers, and so on. And there are different techniques. The ways police are trained are quite different. But also if we contextualize this, when there's escalation and violence in many hospitals and psychiatric units, it's look, Deji, if you do that one more time, we're going to call security. Deji, go to your room. Yeah, but also, Deji, go to your room. Okay, code something. Boom, 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 boom. And then here I am looking, hold on, what's going on here? I may be going through an experience saying they're here to kill you, that the death squad have arrived. No, leave me alone, leave me alone. Elbow, next then, violence, trip, kick, pull, bang on the ground. I may be living with trauma, and some wise person thinks that's the time to inject me. But to inject, pull down my trousers. The last time I had my trousers pulled down, something nasty happened. And I'm going to knock out every single person's tooth that's making me relive that situation. And I'll do that on and on and on because I need to feel safe. I'm not going to let that happen to me. So the location matters as well. And the way escalation's managed on hospital wards, the ward milieu itself, in the ER, outpatients clinic, in a person's home, public place, or the streets, that context really matters. In an old life, when I used to inspect and visit psychiatric wards and evaluate them, I used to carry a device that measures decibels. Some units had the decibels of a motorbike. That's how loud they were. Now, if you were on a unit that sounded like a bike non-stop all day and you just needed peace and quiet, and you were used to going on a walk just to have some quiet time, to have that much noise intrude in your head non-stop is really distressing. The tone of voice, and there's a heck of a difference between asking someone calmly or with a low tone voice or threatening. Look, if you do that one more time, and what are we triggering? Did the person just sound like dad before dad slapped or something nasty happened in their life? Threat or gestures, gesticulation. And there's a lot we can do wrong with the use of our arms when we're gesticulating and so on. Another rookie example, this is again, stupid Deji as a rookie doctor. I'm still a rookie doctor making stupid mistakes, but I was interviewing someone with an interpreter from another part of the world, and the person was homeless and had been supported into a particular space to be assessed and asked questions. And then I very naively asked the person if they're any time I understanding, and the conversation we're having in a language the person didn't understand, the person thought I'd just sentence them to death without gesture. And that person fought. It was so violent, but this person was fighting, believed himself to be fighting for his life. So what we may assume as okay gesticulation in one context may be very triggering for other people as well. Eye contact, and eye contact, there was a give in the eye, and there are different ways of looking and perceiving looks. There's some eye contact, this is uncomfortable, but some eye contact can be reassuring and so on. And how do we gauge this? And what's the experience we bring to bear into these situations? Or language, the language we use, the words we use, the languages spoken, race, body size. If you're 6'7" and built like a wall, there may be some perceptions, either the person trying to de-escalate or the person that's escalated. And how do people respond to people with big body sizes as well? Sex, gender, age, and so on. So the point I'm trying to make here, and this must be all too familiar to all of us here, is escalating situations can have so many things in the background as part of that process. Now, there's a very wise person I spoke with during one of the break sessions, and they said, when you're looking to intervene in these situations, if you think of the person as you would your own brother or sister, what would you do differently? We're going to transition now to part 2, which will be an engagement session. It's going to be a sim type session, and what we hope to do in this session before we invite comments, and I'll break into different bits, is what you might do or what your experience has been to de-escalate in some of these situations. So if you give me a few seconds, I'm just going to get into sim mode. And who better to simulate escalation and aggression with than a learned psychiatrist, professor, a convener of this conference. Drum roll, Simon, the de-escalator.
Is this a weapon or is it a microphone? So one of the things as a clinician is, when and where do I wear a name badge? And I always wear it by default. I sometimes wonder if that's helpful. You come here, mate. Yeah, I have the power. I made him come down here.
So he thinks.
All right.
Okay.
This is looking like a rap act, isn't it?
Chum, chum, chum. Right. So Simon doesn't have a clue what's going to go on because there's no script.
Help me.
Scenario one, I'm going through a psychotic episode. I'm really paranoid and I don't want anyone in my space. And I'm just really, there's stuff going on in my head. Because there's a polite audience, I'm going to use the word SH1T. And then in another world, you can substitute the one for an I. Yeah.
So hey man, how you doing? Yeah. Yeah. What's been going on with you?
Who do you think you are? Who do you hand your pocket? You think you're cool and dinky, eh?
So I was really concerned about people have been concerned as well.
Yeah,
I was wanting to see if there's anything we can do to help. Yeah, and I wanted to see if there's anything we could do to help today with you.
Go help yourself.
Yeah.
Or F yourself.
Okay.
Yeah.
All right.
Yeah.
So usually, okay, come.
Yeah, go ahead.
Okay. So, do you want to come for a walk?
Where are you taking me? Death row?
No, just around the block where you can see here.
Yeah, why should we walk?
Well, because sometimes it's good to walk and talk.
Yeah, last time I left, it sounds stole my jacket, they stole my money and so on. I'm not going to walk.
Really?
You know, you're just going to spring a trap. I bet the feds around the corner, the moment I move around that corner, you're going to trap me with the feds. I'm not going there, no.
Yeah. So what happened with your jacket? Did you get it back?
No.
No.
Well, I saw a jacket, but I saw one of the feds wearing my jacket.
Oh, goodness.
And one of the psychiatrists, one of those bloody psychiatrists in Ottawa Hospital was wearing my jacket.
Yeah?
Yeah.
Yeah.
Thieves.
They like that there.
Yep.
Yeah. Okay.
One of those, some guy called Hatchet.
Yeah. So has anything else happened like that to you?
I don't trust you, man. I don't trust you.
Yeah, look, I'm very understandable.
No, I effing don't
why.
trust because I don't trust you, okay?
Yeah. No, I hear what you say. I'm not asking you to tell me your life story to trust me. I'm just asking to see if there's anything we can do to help today. Because it sounds like you've suffered. People have been.
Yeah, but do you know what's like not have breakfast, not have lunch? Look at you. I mean, you're well fed. I've not eaten anything. You want to talk?
Yeah, do you want a snack?
Yeah.
Okay, let's go and grab a snack.
Okay.
I meant to put a biscuit in my pocket for this role play.
Great. So that's one scenario. Audience participation. What could be done differently? What worked? What doesn't work in that particular scenario? Thoughts, suggestions? We're all in this together.
So this is my neuroscientist brain going online. But one thing you can tap into even when somebody's completely disconnected, whether they're psychotic, they're intoxicated, is usually tapping into those mirror neurons of that empathy. You're really suffering right now. You're really scared. Identifying their emotional thoughts. Simon did a really good job of that. And as soon as he did that, you kind of ease down a little bit.
I always think that's one of the core skills in psychiatry is naming the strong feeling in the room.
Yeah, that was interesting because I could hear my emotions being acknowledged, which was really helpful. And what was interesting is the psychiatrist didn't sort of slap me with their power or raise voice. And when I thumped the table and shouted and rude gestures and so on, I mean, if that had gone into don't thump that table or don't thump that table again, I'm tipping this table over and I'm going to smash up this place real quick. And just the tone, I was trying to escalate the tone. And sometimes when people are shouting, you know, their voice is going up and ours is going up as well. And then before you know, hey, it happens in our homes every day. And then don't shout, I'm not shouting. Oh, yes, you're, no, I'm not. well, you're screaming. No, I'm not even screaming, and the neighbors will hear. And they just, and what Simon did there was not escalate with me. But other thoughts, suggestions, observations? Yes.
I know when I'm de-escalating youth, sometimes naming the emotion is not the best thing, especially with like male youth, because if you say you're scared, I'm gonna get hit in the face. I'm just gonna be very honest with that. But what I do like to do, especially if the youth is like larger than me, is get even smaller and not come off as a threat, but ask them like what happened immediately, because they have some sort of story as to why they are where they are right now. And most of the time they just want to talk about it, but they don't know how to ask to talk about it, if that makes sense.
Fantastic point. And each is situation specific. So in that situation, having asked me what happened, it was silly Simon. Every time I go for lunch, Simon's lying down in my bed. I've told him 100 times over and over and over again. It's an opportunity for me to give my story. You're listening. And the point you make also is to do even the body language. If I come across as big, threat, my fists clenching, and so on, and okay, the adrenaline's going on, but how do we get comfortable with the adrenaline changes in our bodies? Secret. Okay, go ahead.
And I made a very deliberate choice not to stand like that, but stand at the side as well.
Yeah, because standing full on, for the guys here, if you stand full on and not slightly to the side, you could have BALLS becoming eyeballs. With a kick or a punch and so on, it could be pretty awkward. And also you're minimizing, you're not full on threat, you're just going slightly to the side. It's very useful wherever space you're in to do a quick recce. Can I exit from here? Because there are some situations, the wisest thing you can do is run. There's no ego there, just, or at least put some distance behind you. But it's a really good point as well. Any other thoughts, suggestions, experiences? The two hands there. Emeritus.
Hello. Being Portuguese, I can project fairly well without the mic, but thank you. Offering an option rather than challenging that person's perception at the time, and offering them the option to sort of maybe shift their thinking. Let's go for a walk. And so not challenging maybe some of the perception that they were having, which would create that person to escalate further, and making your intentions clear in that moment, why you're there and what you hope to do with them.
So great points as well. So distractions and reducing the ambiguity in the situation. So in that particular time going for the walk, because I was really paranoid, I wasn't sure what was going to happen. Because last time I was taken somewhere and someone said, just follow me here. There's a whole bunch of people and they jumped me. So, hey, who do I trust? Yes.
I was just going to mention that I heard validation a lot in the interaction, which I think is incredibly important that you're recognizing that. But also this, interaction certainly wasn't unfamiliar to, I'm sure, lots of people's work that we do within this room. But this interaction specifically, I think can happen 10 or 15 times before, Snoopy is actually following through to connect with Dr. Hatcher, right? And it's that repeated showing up. And I've had clients say that to me, that even if I don't want to talk to you, and even if I'm not in a place to talk to you, I know you're there and you're available if I do need that. And I think that that's huge. So what I noticed in that is certainly not unfamiliar. It's that you were there and providing that and being available to give that. And just, I don't know, Dr. Hatcher, what was going through your mind, but knowing that this is probably not going to be a quote unquote successful interaction that we have today, but knowing we can repeat it until he knows your name or calls for you to ask for help.
Yeah, well, what I didn't do a very good job of was setting the context, because I wasn't quite sure what the context was at the beginning. And also, I trust how I feel. and I didn't get the hairs rising on the back of my neck sense, which I get, which is always a prelude to me exiting.
So just, you earlier spoke about volume, cadence, tone, inflection, and the words we choose. So oftentimes when I'm confronted with a situation such as yours, and the individual's escalating and their voice is getting louder, I tend to bring my volume down. Then they need to lean in and really listen. And a lot of the times too, and I think somebody brought this up earlier, we feel compelled as clinicians to solve the issue right at that moment. And we tend to natter on, and I'm guilty of it myself, and just want to solve that situation. So I think this taught me that that issue does not have to be solved right at that moment. We can pause, we can take a break, we can come back to it. So it's really important as clinicians that we develop those skills on how to end a conversation and without closing the door completely. So thank you very much. That was a fantastic real life demonstration.
Thank you very much. So what we heard there was actually using tone of voice and inflections to de-escalate. So as the person's getting louder and louder and louder, you're just bringing it gentler and gentler, not recreating threat. In fact, go ahead.
I'm just wondering how you deal with the question of accent, because I very clearly don't have a Canadian accent, but I often introduce myself by saying I've got a funny accent, and I tell people a little bit where I come from. It's how it's one of the things I learned working in New Zealand, working with Maori, is about you share a bit about yourself first. And a situation like this, where the context is unclear and you might be just meeting somebody for the first time in a situation like that, then that's probably not the best thing to do. But in other situations, I actually use the whole accent. So I don't know what do you do? Because you have an accent as well, so I understand.
Dr. Simon thinks he's being clever. Okay, now, now he wants to know if I have an accent. You get an accent today. You have just triggered the next role play. So here I am now. I've come here and, well, I'm from Nigeria. Maybe you've had the accent before, you have not. So I'm here and I'm just walking about. So who are you? They say you are the doctor. Simon Asha, Simon Asha, Simon Asha. Simon Asha, Simon Asha.
Okay, good on you, mate. So whereabouts in Nigeria are you from?
Whereabouts in Nigeria? Have you ever been to Africa? Look at you, white man. You're asking me about Africa.
Yeah, I have been to Africa.
You have been to Africa?
Yeah.
Africa, you think Africa is your hometown in Ottawa? So what do you want?
I just wanted to have a chat with you today.
You want to chat?
See what we could do to help.
Yeah. Why are you talking like that? You're not from Canada. Can you speak Queen's English? What's the matter with you?
So it's good that you notice I don't speak the Queen's English.
No, you don't. I can't speak.
Yeah. So I just for today, this is just wanted to see you because people tell me you're the sort of person I should talk to, and that there's something maybe we could talk about, whether you need any help at all.
The only help you want is...
It's raining inside as well.
Right. So I've just doused, well, I didn't. I drank before then. But that's a situation.
At least it's not COVID where people just spit at me.
Oh, yeah. I collect my spit pictures on my clothing. But again, so here you are in a situation, you're trying to escalate, and the person assaults you. Now, that's been low. We've just used 6 droplets of water. I'm sounding a bit different. Other people arrive, and you may say, an example is, and this is a real example, the person said, hold on for 2 minutes, and then I'll deal with you. Now, deal with, the person who said it intended to say, I'll attend to you. Deal with you is what police in checkpoints in many parts of West Africa do before they beat you up. You know, I will deal with you. No, by the time I finish dealing with you, you become a cat or whatever. So the person then says, so if you say, for instance, to me, please hold on just 5 minutes and then I'll deal with you. You go ahead. Go.
Okay, if you just want to hold on for 5 minutes, I'll deal with you later.
You will deal with me later. You will deal with me. It's me you want to deal with. Now, it's interesting, just looking at Simon, a whole career kicked in. You adjusted your position. He was already leaning on his exit foot.
And in real life, you'd have a sacrificial medical student. You could just put it.
Right, so conversation about that particular scenario. You're speaking with someone who may be less aware culturally of what's going on, or they're living with trauma because the last time that happened, it was in a detention camp or refugee camp or something. What are our experiences? Should I change? Sorry, let me speak the English you understand. Does anyone have comment on that? Because now some of you may try by being very patronizing. You know, when you talk to Black people that you think have strong accents, and then you're enunciating your words. Have you eaten today and so on? But how will you attend to that situation? Because it's happening, and you're part of the team. That door is locked, no running away. Forget that the room is 4007. There's no James Bond here. What will you do now? And sometimes apologizing is a way. I'm really sorry. It's not about your ego. Sometimes you apologize, and it's okay to apologize. It doesn't make you weak. Any other?
What about sitting down? Because people often don't feel threatened by you if you sit down.
And that's a really interesting one, because even if one person's sitting and others standing, so are you sitting as the?
I'm going to sit, yeah.
As the worker?
A doctor, apparently I'm a doctor.
Okay, so you're sitting down.
Yeah.
So why am I here to see you?
We're here to see if there's anything we can do to help. I mean, you're here. I understand things haven't been going that great for you.
Look at you. Look at you. You're sitting as if you're the King of England. Is your name Charles? Are you Charles?
So I really just wanted to see whether we could talk about anything that might help you, because it sounds like, I don't know, have you been sleeping okay recently?
I've been sleeping okay.
I mean, have you been sleeping okay? Because it's sometimes difficult to sleep in places like this.
How can I sleep okay? Do you know where I'm staying? Police come there every night. Is police.
Do they bother you?
They don't bother. I'm a Black man. I see police car. Anytime I see police, my heart wants to cut. It's just doing like that.
Yeah. Okay. And you're getting enough to eat here as well?
I'm getting enough to eat. So I came here. There's no pounded yam. There's no fufu. There's no, and so on. Okay, we'll switch to another scenario. But any comments on that? Because some of us may have found ourselves working with people just culturally so different. What do you do? We heard our colleagues in Toronto talk about working and advocating for people dealing with immigration issues that are so different. Some who'll be disturbed. Now, some cultures, different cultures gesticulate in different ways. But I've not done anything. And so, no, you're being threatening. No, I'm not being threatening. I'm not threatening. No, Deji, you're making me uncomfortable. Or you're being violent. I'm not being violent. If I was violent, I would have slapped you. Have I slapped you? I'm not slapped. Have I slapped you? And then you say I'm threatening you. Yeah.
Okay, good. So I didn't click in. Okay.
Yeah.
If anyone wants to do an Australian accent, speak English and pretend you're drunk.
I was just going to say, the one thing I find really hard in like a situation like that, if it's somebody I don't know, a client that I don't know, like Simon being able to sit down and feel safe or comfortable. Like sometimes the places we're working in, there's so often I find like I'm end up in a room where I don't have an exit and I don't know that person. They might be on a substance and it's really unpredictable. And so it's hard. You want to sit down and be therapeutic and yet like trying to keep your calm and cool while you also kind of don't feel safe. So like that tricky thing of really wanting to be therapeutic and yet also being like, oh fuck. So that's the thing that was what I was thinking. I was like, oh, it's nice Simon can sit because he's got a whole back behind him. But
Yeah.
like the environments we're doing this work in often are so not ideal for being therapeutic.
Valid points. And if you're using a room, don't relinquish the door if you can. Try not to relinquish own the access routes. It's too easy to take someone hostage if they have access to the door. So look at the room design. If you have a seat to offer the one further to the exit point. If you have 10, 15 seconds just to recce the room and check out what's on the table or around. Some rooms will have a fancy doctor's golden letter opener, AKA dagger, or a bottle somewhere. I mean, anything can be used as a weapon, but just get a rough idea. And when I'm in tricky situations, I tune on my most violent brain. I always think, okay, if I'm going to hurt this guy, what am I going to do? And try and get into what the other person may, if it got tricky, what could they use as a weapon against me? But try not to relinquish the door. I speak as someone who's been taken hostage before by someone who was homeless, extremely ill and paranoid. And the person, again, rookie, naive, deji doctor, early career. The person had a Rottweiler, offered the seat, the person shut the door, and the person and the dog were between me and the door. And I was taken hostage for 2 hours. Staff thought, goodness, Deji's spending a long time with this interview. And I was trying to get help and someone knocked her. There's the dog. The person told me, look, this dog has been trained to eat men's anatomical bits. Security were called, security peered, and I think they thought, okay, we're not getting hurt today. Regular police turned up. Nope, we'll call someone else. Dog handlers turned up and thought, okay, rather than a very violent situation, they went pick the guy's mum. The guy's mum arrives, they open the door, the dog wags its tail after glaring at me, and then they could handle the situation. So what I'm saying is it could happen to any of us in a whole range of different contexts. Any other interventions for those ones? Yes.
I find it interesting that what you're talking about is something frontline workers face literally all the time in terms of being held hostage, whether it's like the conversation itself or the physical location or space, whatever that might be. And I know in programs that I've worked in, that's when we're doing like tap-ins, tap-outs. We're checking in with like our other coworkers on shift so they know where we're located in the house and like making sure we have our safety buttons on us. And I mean, you guys are frontline workers too. So I don't know, how do you guys keep yourselves safe? Because some of these things, it's like, it's that prevention before it even gets
Exactly.
to that point. So that we're watching out for each other as well as the other clients.
What pearls of wisdom do your colleagues want to share? Go ahead.
I won't lie, I'm somewhat of the worst for this. It's usually after a situation, I'll be like, oh, wow, I was like the other side of the door and sitting down. That was not a great choice on my part. But definitely like acknowledging feelings. If it's somebody with a cultural difference, I will always acknowledge where I'm like, hey, I am the little white girl whose most of my drug use happened in university. Like I am speaking from an immense amount of privilege here and just acknowledging it immediately, especially if they start bringing it up to be like, you're not wrong. Apologizing is a good one. I've always thought that most of my clients have probably never had somebody apologize to them when they have treated them terribly. So if somebody is calling me on a mistake, whether or not I feel the need to justify what happened, I will always apologize and say, no, you are correct. I shouldn't have done that. I'm sorry, but here is where we are. And also whenever I have clients, I've had clients get mad at me and like yell all the things they're mad about. And sometimes it's just respecting that I'm the face of the system and just kind of, as shitty as it is, taking the brunt of the anger, like, especially if it isn't a violent anger, they're just mad. They're like, my stuff was stolen. I am in control of nobody's stuff, but yes, that's terrible. And I'm sorry that happened to you again. Sort of like going over that and just being the face. This is like, I've only ever been hit once. It was by accident. The guy next to me dodged the punch that was for him and he didn't tell me. But beyond that, I've found that those are effective for me as someone who has been very rarely threatened.
Yeah. I mean, you
yeah.
make a really good point there. Sometimes it's worth that time just soaking up the verbal anger. A person's angered and on and on. And you're just soaking it up. I mean, it's no fun. You're soaking it up. And then the person will say, so, aren't you saying anything? I'm really sorry. And I've actually found quite helpful, I speak for myself, quite helpful apologizing to people for the experiences they've had with the police or in the ER and so on. Don't defend a whole system. There's no point. You know, I'm really sorry that happened in the emergency room. That wasn't nice, and so on. And apologize. You don't lose. And for some people, as we heard, some people never hear sorry. And they're just not, people don't even say sorry to them. Any others before I go into another? Oh, is that yes, there's a hand up there. Oh, the mic's trotting, that's my therapist.
Just to kind of add on to the idea of apologizing, I also find just the acknowledging of the systemic injustices have been really helpful over the years. And just like, even I'm thinking of how many appointments I've been in with somebody where they'll tell their story, the professional in front of them won't listen, but then I say almost exactly the same thing. And you can just see them getting smaller. And so it's like walking out and just owning it and being like, hey, that was really fucked up. That you said exactly what I said and they didn't listen to you. And in most of, like, so many of the situations when people are angry, just to acknowledge how messed up the system is right now because they're living it. And I think often, you know, people just don't say what's happening and that it's not okay. Like, it is not okay that we did not get enough money for homelessness in the city this year, right? Like, and it's going to drastically affect people. And I've always found that helpful, and just being incredibly authentic, because people who've experienced trauma will notice when I'm scared. And so sometimes I will even say that, like, you know, this is what I'm feeling right now, because they already know it. They might not, you know, be saying it, but they can tell if I'm scared. So in a situation, I will sometimes say, like, I'm a bit uncomfortable here, and then we shift. Depends on the relationship with the person, obviously, but.
So in a sense, in some situations, choosing to validate the person's experience. Yeah. There's another person just behind you, and then the person, I think there's someone in a black and white top as well. No, you. Yeah.
All right, is this on? All right. Sorry, I might I'm a person with, I don't know, I don't call it lived experience. I'm a person that was like drastically hurt by the Ottawa hospital. I'll be completely honest. I'm sorry if there's anybody that's practiced at the General, Civic, Royal, or CHIO in this room. I had my first mental health crisis, they called it, when I was 12 years old, and my last one when I was 30. I don't fucking know. Sorry for swearing. And I get the idea of apologizing, but I think change of behavior needs to come before an apology. If you show up to me to apologize and then act the same way, I'm not going to buy it, and it's just going to escalate me more. I think I've been a violent patient. I'm labeled, I think, probably still the Ottawa hospital as a violent patient, because we all share charts, which sucks. And I've been restrained in beds by doctors and medicated by psychiatrists. And And nobody explained to me why after. And when you're in that like psychotic break or like mental health break, you don't know necessarily what you're doing. You throw water, you throw chairs, you kick a security guard in the nuts at Chio. And sorry, I did. I laughed at the time, I guess they told me, but all I remember is waking up at the hospital alone and in a bed, right? And nobody came to me to talk about the situation after, but all the doctors, nurses, and security guards talked about the situation. And I've had that happen in shelters in my life, right? Where we talk about the situation and we talk about the person and we have case conferences and meetings. And we are like I work in frontline now. I work with doctors, physicians, and psychiatrists, and I get to share like my experience. And I think the biggest thing is we go into things and we're like, it's unsafe for us, but we don't, that client might be a stranger to you, but you're a stranger to them just as much, right? So I think like trying to change the behavior, not justify it, and apologizing for the systems, but challenging the systems. And I know that's probably like really hard. I tell medical students this all the time. They're like, what can I do to be more like, to reduce harm and to be a better doctor when I graduate or whatever? And I'm like, hold a mirror to the people that are hurting people, right? Speak up when you see people acting in ways that aren't that, right? Like, and de-escalate in a way by communicating with the people that are causing harm, whether it's a patient or another practitioner. That's it for me.
Thank you very much. And thanks for sharing very personal experiences with us. And one of the takeaway points from all you said was also the importance and the value of actually having a debrief afterwards. Because things can happen when we're in a state of confusion or we're ill and so on. And just the debrief can help the person also make sense of the situation. Otherwise, the enduring memory is what happened. I went there, 6 people jumped me, I was injected, I was shouting, help, help. And I've got bruises all over my body. And just that debrief to help the person make sense. A caring, compassion, not an officious debrief, but really caring and compassionate and kind can go a long way. Thanks for that. We've got someone else with the mic?
Thanks for sharing. Yeah, what that made me think of was, I think what works most of the time for me is to remember that an escalation is a way to meet needs and to access power that is often not available to the folks I serve. So the best thing that I am able to do most of the time is to allow people to take power and to regulate enough that I am showing up as safety for folks. I think if people read safety in me, then 90% of the time they de-escalate with me because they think I can relax in this person's presence. We just finished running a winter overnight drop-in for folks, and it is incredible to see the difference in different staff. So when folks read that staff are nervous and scared around them, then the survival technique is to take charge. And sometimes that's through escalation. And when a competent, really experienced staff comes in and they feel that, then everyone's asleep in 15 minutes. So yeah, that's the best thing I can do is like regulate, make sure I'm not presenting with fear, provide some safety.
And you make some fantastic points there. And one thing I've learned and I continue to learn is anytime I'm in the shelter and so on, it's amazing seeing peers or people who work in shelters, watching them de-escalate. I mean, there was someone I'd seen in hospital. It took 6 security and really violent incident that took nearly 2 hours. And I saw the person manifest exactly the same behavior in a shelter. And a peer support worker who was probably half the person's size, I mean, I exaggerate there, just walked up to the person, put an arm, no, come along, buddy. Let's go have a smoke. I'm not, smoking's bad for you, but this is what the person did. Let's go have a smoke and a cup of tea. And I was observing, and 15 minutes later, they were sat really quietly on a rock, just talking. There was no violence. And I implore all of us, when we're in these situations, actually to learn, because there are techniques that people use. There's someone that spoke some words of wisdom. Are you okay with a mic? Okay. Okay, the person's not okay with a mic, but I'll still quote the words of wisdom when we had a quiet chat. And what my learned colleague and friend said was, if you can sort of visualize the person as your own sibling or loved one and so on, how do you manage them when they were disturbed?